Okay, so you've got 5 minutes for your presentation. We'll give you a 1 minute warning when your time is almost up. So what would you like to tell us about your patient today?
So this is Mr. Jones. Mr. Jones is 64 years of age, and he's a window cleaner. Mr. Jones has angina, and he's had angina for 3 years. He's also a smoker, and he smokes 40 cigarettes a day. He used to smoke 60 cigarettes, but he's on 40 cigarettes a day. He's got calluses on his right foot, on the second and the fifth metatarsophalangeal joints, and also on the plantar aspect of his big toe on the right foot. In terms of drugs, he's got GTN spray that he uses, and is on atorvastatin, and he's recently been prescribed ramipril. So that led me to do a vascular assessment, and I could find the pulses, but they weren't very strong. But I did manage to find them. Mr. Jones also says that he gets cramping in his legs after he's been walking for a while. So I did wonder about whether or not there was claudication taking place there. So because of the callus patterns that he has, I did a joint range of motion, and the joint range of motion showed that on the right foot there was 5 degrees of dorsiflexion, and then on the left foot, and the left foot's also got hallux adductovalgus, so on the left foot it was a bit more than that. So that led me to do a JAX test. And on the JAX test, it was both feet were 1, according to the gauging of the JAX test. Now there's no venous insufficiency that's there, but because this gentleman he's taken his ramipril because of his high blood pressure, I did a neurological assessment, and there was he could feel everything all right, so there was no issues with that one. And what I've done, or I'm going to do, is I'm going to reduce all of these calluses, and then what I think we need to do is kind of do some offloading and kind of redistribute the pressure. So I was thinking about doing a kinetic wedge. I think that might be something that's worth doing, and then we would review this patient.
You've got 1 minute left.
Review the patient in 8 weeks' time.
Okay, thank you. So you've given us quite a bit of detail, thanks for your presentation. So there's just a few areas I want to explore a bit further with you, and then Pamela might have some questions for you as well at the end. So you mentioned in your presentation that there was callus on the plantar aspect of the big toe. Could you be a bit more specific with regard to the location of the callus, and explain to us why you think that callus is there?
Callus is on the plantar aspect of the interphalangeal joint
Okay.
on the first toe.
Mhm. And why do you think that it's there?
There's been too much pressure
Too much pressure.
on that area, so when the patient's walking, they're getting too much pressure
Okay.
on that area, and it ends up with hyperkeratinization, so you get the callus bit.
So why do you think there's too much pressure on the hallux?
Be because the way the person's walking. So when they're walking, they're putting more pressure on that area than the joint's designed to take, and therefore the hard skin builds up.
Okay. So I take that there's too much pressure because of the way that they're walking.
Yeah.
So why is there too much pressure? Why do you think there's too much pressure in that area?
If the joints aren't working properly, then that
Which joints?
the metatarsal phalangeal joint.
The metatarsal phalangeal joint?
Yeah.
Which one?
The first one.
Okay. So the first metatarsal phalangeal joint isn't working correctly, which is leading to too much pressure,
Yeah.
which is giving you the callus.
Yeah.
Okay. So how do you know that the first metatarsal phalangeal joint isn't working
Well,
correctly?
when I checked, I did a range of motion, and it wasn't moving enough. And then with Jack's test, it was giving me a 1.
Okay, so talk me through what you found in your open chain assessment of the first metatarsal phalangeal joint. What was it?
So when I had them stood down, and I got a 1 for a Jack's test.
What do you understand by the term open chain?
Oh, so when I was assessing them on the chair, then there was limitation in movement of the first metatarsal phalangeal joint. I couldn't get full dorsiflexion.
And what would you expect to find?
At 90 degrees of dorsiflexion. 120. 70.
In a normal joint, no pathology, what would be the normal amount of dorsiflexion in that joint?
It's gone. It's gone.
You told me that you'd made an assessment that it wasn't enough. So how can you make that judgment without knowing what the normal range would be? Were there any other things, if you don't know the actual value, what else about that?
Well, it wasn't moving very much,
Okay.
but I don't know. I've forgotten. I can't get to you what the actual.
So if we forget about the value for now,
Yeah.
what other features of joint motion were you assessing rather than just the amount?
Whether it moved.
Sorry?
Whether it moved.
Whether it moved, yeah, okay. So that's the amount of motion. What else could tell you whether this was a normal joint or not? Okay, we'll leave that for now. So we'll forget about that for the moment. But based on your judgment that there wasn't enough dorsiflexion, I'd still like you to explain why the callus is there. So let's assume that there was not enough dorsiflexion. why would that callus be present on the plantar aspect of the IPG?
Because if the metatarsophalangeal joint isn't working properly,
Mm-hmm.
The weight will come forward, so that joint can't take it, so it goes up a joint.
Okay.
So it's doing a bit more work than it's designed to do. So the pressure is increased. So when the person's walking.
Okay. So you've also mentioned, further to your open chain assessment, that you then went on to undertake a JACS test. Can you describe to me the rationale for undertaking the JACS test and what that has told you about what that's added?
Well, you do that test to see whether or not they've got a functional hallux limitus. That's what you do that one for.
Okay.
And they've got a functional hallux limitus.
They've got a functional.
Yeah.
So what is the other type of hallux limitus that you can get?
Hallux rigidus.
No, hallux limitus. There's functional, or what's the other type?
Anatomical.
Okay.
Structural.
Structural. Right. Okay. So based on your assessment, your open chain and your closed chain assessment, your decision about the type of pathology affecting this joint is that it's a functional hallux limitus. Okay. One other question, just before I move on to management, was that you told us that you'd undertaken a neurological assessment based on the fact that there was hypertension present. Could you expand on that for us as to what led you to undertake that neurological assessment?
Well, when you're doing a vascular assessment, you do a neurological assessment.
Always, routinely?
That's what I've seen, yes. Yeah.
That's what you've seen. So if you do vascular, then you've always got to do a neurological.
Yep. Yes.
Okay. So my final question is really about your management. So based on your findings, where there was a limitation of dorsiflexion and then you found limitation on weight bearing, your management was a kinetic wedge. Can you just describe to us the therapeutic objective of the kinetic wedge?
Well, so that's a wedge that, like on the orthotic, kind of works kinetically when the patient's walking to shift the load from the where they're getting high pressure. It means that the forces go somewhere else.
Where do they go?
To other parts of the foot that have got the movement to let that work.
So in this case, where would that be?
So with a kinetic wedge it would push it over to the lateral side, so that it wasn't so much on the medial side, because they've got that hallux limitus, functional hallux limitus thing.
Okay,
going on.
Thanks. So Pamela's just got a couple of questions for you now.
Identified Mr. Jones is presenting with a history of angina. Can you tell me what type of angina he presents with, and more importantly, how this affects him?
It's the angina where you get pain in chest on exertion, and because of this, Mr. Jones has got GTN spray that he takes, and he takes yeah, he's got his GTN spray, so that's...
And he has it on him today? He has his GTN spray on him today?
I don't know, I haven't actually asked him.
Okay. When was Mr. Jones' last angina attack?
I didn't actually. I didn't ask.
Okay. Moving on, you identified Mr. Jones as presenting with cramping in his legs. Can you expand on why you believe this was intermittent claudication?
Because with intermittent claudication, it's when a patient gets pain in the calves when they're walking, and when they stop walking, the pain goes away, and when they start walking again, it might come back again, and it's not unusual for patients who have got angina to also get intermittent claudication.
Okay, can you explore why it's not unusual for someone with angina to present with claudication?
So as there's atherosclerosis, so hardening of the arteries, that can affect the heart and that can affect the legs as well.
And is there any evidence of atherosclerosis affecting Mr. Jones' lower limb and foot?
Claudication.
Okay. What would be one of the distinguishing features between intermittent claudication and another type of presentation? Would you like me to reframe that?
Thank you.
Okay. Is there any particular characteristic that you'd always expect to present with intermittent claudication?
Pain when somebody's walking, often in the calf, that goes when they rest.
Okay. And is there normally a particular distance that someone would have to walk?
There's a claudication distance.
And what is that?
It's the distance that somebody walks before they get the pain in the leg.
Okay. And at what point does that become pathological? Does that distance become pathological?
When it starts to become painful.
Okay. Have you heard of the Fontaine classification?
I've heard of it, but I can't remember it.
Okay. That's fine.
Thank you.